Good morning, everybody. We're going to make a start in about 10 seconds. An echo. Okay, thank you. Okay, thank you. Good morning, everybody. Welcome to this meeting of the Health and Wellbeing Board. I'm Sarah Webster. I'm the ICB Director for West Berkshire, Wokingham and Reading, and the Vice Chair of this board, and I'll be chairing today's meeting. Before we start, I'd just like to explain for the benefit of the public who may be watching that today's meeting is being held in a hybrid format. We have a quorum of board members in the council chamber, with other board members attending remotely as well. And also a welcome to members of the public who've joined us today for today's meeting. This meeting is being live streamed via YouTube, so members of the public who aren't present in the room are able to follow proceedings as well. Gordon Oliver is the clerk for the meeting and will be making sure I stay on track and do all the formalities that I'm meant to be doing. And Sam Chiverton is our Zoom host today. Just a couple of processy bits before we start. So in the event of a fire alarm, we must leave the building immediately via the emergency exits. The assembly point is in the Dolphin car park. If the lockdown alarm sounds, we will remain seated and await instructions from officers, and we'll adjourn the meeting until such time as it is safe to proceed. Do members have any questions about the way in which the meeting will be conducted? No, I think we could all probably read that in unison now after many meetings together. So turning to the agenda. So Gordon, have we had any apologies through for today?
Yes, Chair. Councillor Alan Macro has given us apologies and Councillor Vicky Poole is substituting. Councillor Joanne Stewart has given her apologies and Councillor Dominic Bowick is substituting. Matt Hensby has given us apologies. Superintendent Andy Penrith has given us apologies and Chief Inspector David Whiteacre is substituting. I haven't seen him yet, but he's supposed to join us. And Dr. Janet Lippett has given her apologies and Helen Williamson has given her apologies.
Okay, thank you very much. So I'll move on then to the minutes of the last meeting, and thank you very much for preparing those. Are members happy to approve the minutes of the meeting, or are there any changes needed? Heather, Councillor Quadlin.
Yeah, I thought we requested last time that we put send review on here for the forward plan for September, and I can't see it on the forward plan, and I can't see that request being in the minutes.
Okay, I think should we follow that one up? Because I think I recall that as well, actually. I think that'd be helpful. Thank you. Are there any other comments? Councillor Burke?
Thank you. I don't know whether this is a question for the minutes or kind of like a matters arising, but I just wondered on members' questions. There's a link to transcription of the questions and answers. And I have a question around one of the answers to one of the questioners. Can I raise that now? So
Yep.
Paula Saunderson raised a question on dementia, specifically a question around the dementia pathway, which didn't seem to be answered in the transcription. She also asked a question about, a supplementary on dementia admiral nurses, which was taken away. So I wondered, where people who are following this meeting, members of the public who are following this meeting, where they would find those answers.
I'll take that back and talk to my team manager about that and just see what the process is for dealing with follow-up questions.
And specifically, has Ms. Saunders received answers to these questions? I think that's a really important. She has she? What, in writing?
I believe so, yes.
Can you perhaps take an action to confirm that at a subsequent meeting? Thank you.
Thank you. Really important points. Are there any other questions or comments? No. Okay, then. So subject to the two changes just noted today, can I propose that we take a vote on approving these minutes? And can I seek a seconder for that? Thank you very much. And then a formal vote. So those in favour of approving the minutes? Those against? Excellent, thank you. We can confirm those are approved, subject to the amendments noted today. So moving on to the actions arising from the previous meeting. Noted the point just raised, and we'll review and add any additional actions if needed. I'd just note that there's a couple on there around the cost of living crisis that are awaiting an update, but we've got that on the agenda today, so we'll hopefully be able to cover that off then. And Gordon, there's one on the Health Watch report around asylum seekers that doesn't have an update, so can we follow that one up outside of the meeting, ready for next one? Unless, Sean, did you want to come in on that one?
I can, Chair. I mean, the actions were dealt with at the time. Obviously, the asylum facilities in the area have now closed in any case, but they were picked up at the time following the meeting.
Okay, thank you very much. So it sounds like we can probably close that one then. Thank you. Can I check if there are any other updates or questions in relating to any of the actions? Councillor Burke?
Thanks. Just including that point, the asylum seeker point, there are 4 items here which have no status.
Yes, so 3 of those are on the cost of living crisis. So Sean will be, which is on the agenda today.
Okay.
So we can hopefully cover that off, but it will be worth looping back to make sure that we've got the updates on those actions.
I mean, not really important points, but reporting should show what the status is, shouldn't it?
Yes, yeah, okay, we'll take that back to make sure we have that captured for the next meeting. Thank you. Okay, no other, April?
Sarah, just to give a further, sorry, Chair, to give a further update around the vaping. We had the conversation about vaping last time and giving parents more information. Just to say that an information leaflet has been produced and it has now been shared out with schools. So there's I checked on that the other day.
Brilliant. Thank you very much for the update. We'll make sure that's captured as well. Thank you. And we've got a question from Rachel on the online.
Thank you, Chair. It was just a.
You're on mute, I think.
Can you hear me now?
Oh, hang on, Sam. Have we got speakers on in the room? Sorry, just bear with us for one moment.
Should work.
Can we try again?
Okay. Can you hear me now, Chair?
Yes, thank you.
Super. It was just to give an update on action reference 258, where there was an action on myself and Gary to meet with April to discuss the voluntary sector coordinating with the health and wellbeing subgroups. Just to give you a bit of an update, Gordon has kindly sent me across a reporting template, and we shared that with our voice chairs yesterday, and we are happy to use that template, and we'll generate that through to the health and wellbeing subgroup. But April and I haven't yet met, so it's just to kind of bring that to it. We've got a bit of a fruition, and hopefully that will be agreeable going forward.
Thank you. That's a really helpful update. It's really important that we are weaving that work into the work of the subgroups, and then hearing about that through the steering group and through to this board as well. Brilliant. Thank you very much. Check for any final questions or comments. No, well, thank you very much. So I'll move on to item 4, declarations of interest. Are there any declarations of interest relating to the agenda other than those that have been noted as standard in the papers? No, okay, good to know. Thank you very much. And then we'll move on to public questions. So do we have Paula online? So we may be joined in a moment by Paula Sanderson. I'd like to thank Paula, who's submitted all of the questions for today's Health and Wellbeing Board, and is planning on, or we're hoping she'll be able to join us on Zoom. Your questions will appear on screen. Will be answered by the relevant Health and Wellbeing Board member, which today is me. You'll then be given the opportunity to ask any supplementary questions, but this must only be to clarify the response provided and not introduce any new business. So,
would it be possible to position the supplementary questions with a tiny little bit of information?
Just to confirm that the supplementary should only be to clarify the answer that you receive, and it shouldn't be to introduce any new information.
Thank you. So the first question was submitted to myself, the ICB Exec Director for Berkshire West Place, and I'll read out the question and then I'll read out the answer. So the question was, how is the review of the awarding of NHS CHC, which is continuing healthcare, within West Berkshire coming along? Who is conducting the review? When will it report, please? As this is over 3 years since I raised the issues with awarding of continuing healthcare in West Berkshire, and a review was agreed. So the response from the ICB, which I'll read out, is Berkshire West Place has consistently reported a conversion rate for standard NHS continuing healthcare CHC eligibility that is lower than the 5th percentile nationally when compared with organisations that are like them in terms of overall patient demographics. In January 2024, 4 independent chairs who chair independent review panels in the South East region were asked via NHS England to undertake an independent case review audit of Berkshire West Place, which covers West Berkshire, Reading and Wokingham. The report was shared with the ICB on the 15th of April 2024 and will be discussed with NHS England and the 3 Berkshire West local authorities in order to agree a joint approach to implementation of the proposed recommendations. Do you have a supplementary question, Paula?
Yes, so how will that be presented to the Health and Wellbeing Board that through which the review was requested? How will the public get to see the results of that review?
Thank you. So if it's not already, then we need to have CHC on the forward plan for this board. And we'll make sure that the output from that review and the actions that are being taken as a result are shared as part of that agenda item at a future Health and Wellbeing Board.
Thank you.
Thank you. So I'll move on to the second question. Again, thank you, Paula. And this is also submitted to the ICB Executive Director myself for Berkshire West Place. So I'll read out the question, which is, why are West Berkshire Adult Social Care and the Bob NHS CHC Fast Track team placing people with late stage dementia into care and nursing homes that do not list dementia care amongst their services? For example, in 2 Bupa homes, Bayford House Care Home and the Donington Care Home. So the ICB's response to this is, the ICB is unable to comment on placements made by West Berkshire Adult Social Care, although Paul Coe, who is the Executive Director of Adult Social Care here at West Berkshire, has prepared a response to that aspect of your question that relates to the West Berkshire Council's Adult Social Care Service. He's unable to attend today to provide his response, so we will provide in writing after the meeting. From an ICB perspective, the ICB commissioning team works with a variety of providers when sourcing care for individuals. All providers are asked to undertake their own assessment of an individual's needs in order for them to confirm, as part of their CQC registration, that they are able to meet the assessed need. Whilst an individual may have a diagnosis of dementia, this may be secondary to their palliative or end-of-life needs, for example. Paula, do you have a supplementary question?
Yes, I'd like to know who to write to give a recent example where somebody was transferred into a care home that doesn't do dementia, died within 36 hours and was unable to be placed in the room horizontally and had to be put in a wheelchair and removed by the undertaker in a vertical position.
Thank you, Paula. I'm sorry to hear that. So there is
to be honest, it was a very unsuitable placing for the final 36 hours of somebody's life. So I'm not going, this isn't a witch hunt. I just want to give you information.
No.
So that review needs to look at the rooms you're purchasing and their suitability to especially access and size for somebody on palliative care, because to remove somebody in a vertical position from a care home and not be able to get them out of the emergency exit was quite distressing for everybody involved. And that happened to be my mother last Saturday.
Okay, thank you, Paula, and I'm sorry to hear about that. The ICB has a patient advice and liaison service and a complaints line, and we can ensure that the formal contact details are shared with you. And I'm also contactable as the chair, well, today's chair, not promoting myself, the vice chair of this board as well. So we'll make sure my contact details can be shared as well.
Thank you very much.
Thank you, Paula.
Hello.
So we do have, there was a third question as well that Paula, you submitted. Unfortunately, Paul Coe, as I've mentioned, is not available today to provide a response to your question. So we'll provide a written response after this meeting.
Okay, there just does seem to be, I attended a carers drop-in, which poor Steve Hammond was running, who's the only resource on, and there seems to be a bit of a disconnect between the carers partnership and Berkshire West, dementia friendly Berkshire West. So again, it's feedback, please.
Okay, thank you. So we'll provide a response to the question. If you've then got any supplementary or further questions as a result, we can take that forward from there. Okay.
Thank you for your time today.
Thank you very much. And we haven't received any other questions, so that draws that agenda item to a close. So we'll move on to item 6, which is petitions. And Gordon, have any petitions been submitted to the Health and Wellbeing Board?
No, Chair, we haven't received any petitions.
Okay, thank you. So item 7, membership of the Health and Wellbeing Board. This is on an organisational basis, but we have a standing agenda item to note any changes in personnel. So 2 to note for today. So Andy Penrith has replaced Helen Kenny as the Thames Valley Police representative. And Rachel Peters has replaced Gary Paulson as the voluntary sector representative as well. And welcome to both of you to the board. So moving on to our substantive items on the agenda. So item 8 is the Berkshire West Health Protection Board. And I'd like to invite April Pebbody to present this item, please.
Thank you, Chair. So the report proposes establishment of a Berkshire Health Protection and Resilience Partnership Board. Health protection activities seek to prevent or reduce the harm caused by infectious diseases and minimise the health impacts from hazards. Temporary working arrangements were established during the pandemic, which provided a mechanism for delivering against national guidance with a focus on COVID-19. There is a requirement now for a permanent governance structure to protect the health of residents. The board's objectives are to assure, through a reporting framework for each local authority, that partners are undertaking effective and efficient discharge of duties, provide strategic direction for health protection, horizon scan for emerging risks, provide a forum for the scrutiny of the provision of health protection duties. The Health and Wellbeing Board are asked to endorse the establishment of the board, which provides assurance that robust arrangements are in place to protect the health of residents in West Berkshire, Reading and Wokingham. The board are asked to accept the terms of reference at Appendix A.
Thank you very much, April. I will invite members of the board to ask any questions or clarifications on this item. Oh, yes.
Yeah, Chair. Just to say that I very much support this. I think we learned a lot during the period of the pandemic, and I think there's a lot to take into this board. Looking at the terms of reference, my feeling is that they look right, and certainly the membership, I think, basically captures the people that need and the organisations that need to be there. And I'm very pleased actually to see that the role of environmental health as well has been picked up on the board. So I very much support it.
Thank you very much. Councillor Brooks.
Thank you. Yes, we are supportive of this. I wonder if we might add an annual report. It's going to put a work programme together, but I think all these boards that are established should, and I'm looking here at Scrutiny Commission, Health Scrutiny, to do an annual report of what has been looked at, what has been delivered, what has been achieved, as a routine aspect of their work.
Thank you. April, did you want to comment on that?
Absolutely. I think that's a really good idea, and I'll feed that back. I think our Director of Public Health, is John on the call? John, I don't know whether...
I'm here. Did you want me? No, I think that's a welcome suggestion. you know, it's absolutely spot on. I think that's what we should be doing.
Can I therefore have it resolved, please? I'm making a proposal.
Yes, yep. So Councillor Brooks is proposing. Could I have a seconder? Thank you very much. And let's take a vote on the proposal. So all those in favour? All those against? Excellent. Okay, thank you.
Thank you very much indeed.
My first unprompted formality. I hope that went okay. Are there any other comments or suggestions? I think we also just want to follow up then that is on the forward plan for this board and considered through the steering group as well as an action. So the recommendations are for the board to endorse the establishment of this board to provide assurance that robust arrangements are in place to protect the health of residents across Berkshire West, and to accept the drafted terms of reference for the Health and Protection and Resilience Partnership Board as set out in Appendix A. So I'm going to propose that we do accept those recommendations. Can I get a seconder? Thank you very much. And let's take a vote. So all those in favour? Thank you. Those against? Excellent. So we can accept those recommendations. Thank you very much. So I'll move on to item 9, which is our Berkshire Suicide Prevention Strategy. And Zoe Campbell is going to present this report for us today.
Thank you, Chair. This report provides an update on the Berkshire 21 to 26 Suicide Prevention Strategy and proposal for local implementation. The Berkshire strategy was developed in 2020 and endorsed by Health and Wellbeing Board in October 21. In July 22, it was recommended to the board to refresh the strategy due to changes in the policy which coincided with significant changes to the local public health and healthcare system. Due to these circumstances, the Berkshire strategy was not universally adopted by all 6 local authorities. Consequently, the coordination, production and oversight of the strategy refresh was delayed. On the 11th of September 23, the government published a national 5-year cross-sector suicide prevention strategy with a national action plan. A revised Pan-Berkshire action plan has now been developed, including targets and actions aligned with the original Berkshire strategy and latest national strategy. The national strategy highlights the importance of suicide prevention being everyone's business. The strategy aims to reduce suicide rates over the next 5 years, improve support for people who have self-harmed, improve support for people bereaved by suicide. After reviewing the national strategy, Berkshire local authorities agreed to refresh plans at a local operational level. The following actions have been identified: continued investment in commissioned bereavement support services, review of the real-time surveillance system, review of the Berkshire Suicide Prevention Group, and a suicide audit for Berkshire. The board is asked to endorse the Berkshire-wide approach, approve the revised action plan and proposal for a refresh in 25, so work can be steered and implemented through a local multi-agency group, making suicide prevention everyone's business in West Berkshire. A refresh in 25 will allow time to set up and build the existing working group and develop a local plan for West Berkshire, with a view to come back next March to outline progress and proposals for 25-6. The board is asked to offer support for involvement of their organisations in the multi-agency group to ensure engagement across the whole system, and for the ICB to assure or take action to assure that bereavement support services are sustainably funded. Thank you.
Thank you, Zoe. I'll also invite John Ashton, our Director of Public Health, to add anything or comment on that if he'd like to before we open up for wider discussion.
No, there isn't a lot to say. I think because of all the organisational change, this has fallen behind. And what we've been trying to do over the last few months is bring it back up to speed and on the radar across the whole of the county, but also at the local level. And what the directors of public health in Berkshire have agreed is that we really need action very locally but we need a strategy that's at a higher level. So that's what the work is now indicating. So I hope that the board will feel able to support this and look forward to making progress. The thing about suicide prevention is that it's a challenge to make it visible. The tragedy of suicide, which is at a national level runs into the thousands, but at the local level is only by and large a few dozen of these tragic deaths every year. So it makes it difficult to discern trends and patterns with small numbers, which is why it's important to take an overview that's a bigger population levels to see what's going on. But the interventions need to be very locally focused. And then apart from suicide prevention awareness among frontline workers of all kinds, the kind of measures that need to be implemented require a forensic focus on, for example, suicide hotspots, the places where people go to take their lives, and where there may be a possibility to have environmental measures to discourage people. For example, we know that if there are places where people go to take their own lives, then actually having Samaritans details and information and phone number at those locations can discourage people at the last moment. On the other hand, there can be specific places that need physical measures. I can quote from my own experience when I was working in Cumbria that we had a motorway bridge that was actually quite near the psychiatric hospital, and which nobody had seen fit to put fencing up on the bridge, and it had become a place where from time to time people went to jump onto the motorway. So you need a very local forensic set of interventions, and by doing so, hopefully over a period of a number of years, you can reduce the toll by 10, 20, 30% overall. So that's what we need to be doing. I hope that helps.
Thank you, John. And Rachel, I see you've got your hand up. I'll bring you in.
Thank you, Chair. Thank you for the report. It's very interesting. I just had one question. Obviously, the West Berkshire Suicide Prevention Action Group is chaired by our ex-director, Gary Paulson, and I just wondered what engagement there had been with that group with regards to putting together this report. But also to pick up on John's point, some of the local actions that this group have delivered on have been environmental interventions, like putting signage in hotspots on motorway bridges and in key areas, top of car parks and things like that. So they are doing local work. And I guess what I'm just wondering is what place is there for them within this, because they're already well established and doing great things.
Thank you. Zoe, did you want to come back on that?
Thank you, Rachel. So the consultant in public health, Mike Bridges, who was working on this previously, we did have a discussion with Gary and talk about this report further. It was Charlotte Pavitt, who is now the interim consultant in public health. And I don't know if any further conversations were had with Gary in terms of the content, but he is aware of the detail and happy to feed that back and make sure that we liaise with you.
Absolutely,
Gary.
thank you. Yeah, it's a bit of a, obviously it sits, the suicide prevention outreach worker is employed by the Volunteer Centre West Berks, and Gary has continued to chair the West Berkshire SPAG in a voluntary capacity because he was part of the setting it up and knows the ins and outs. So we kind of have those regular updates.
It might be helpful, Rachel, if you had a conversation with Charlotte offline. Yeah, Charlotte Pavitt.
Yes, I've got her contact info. Thank you, John.
Thank you. We might come back onto that in a moment when we're talking about the recommendations, but I will bring in David Marsh online as well with your hand up.
Yes, thank you, Chair. Just briefly, I'd like to endorse what's been said. As someone who's been personally affected by this, lost a close family member to suicide, I just want to say the points in the report about bereavement counselling and support for you couldn't really overestimate the effect this can have on families, and it's really vital. I was very fortunate in that my employer provided extensive support through bereavement counselling, which my employer paid for over quite a long period of time, and that's not necessarily available to everyone. So it's really important that the local services put people in touch with bereavement counselling, and can help both immediately as the report says at the time of the incident, and also ongoing. I spoke to somebody the other day who'd been affected by this 20 years ago, and they were still feeling the repercussions of the suicide in their family. Thank you, Chair.
Thank you. Thank you.
So could I just comment on that?
Yes, John.
I think, Councillor Marsh, I think sudden traumatic loss, which is wider and which our family has been affected by as well, has ramifications which extend, as you say, down the years, and you never completely get over it at all. So it is very important to have things in place. I'm not as familiar as I would like to be with the more informal side in West Berkshire. In Cumbria, when I was Director of Public Health there, we set up SOBS groups, Survivors of Bereavement by Suicide, which are families and close friends who've been affected themselves, providing support to others. And that seems to be a very valuable tool. But I think these kind of options will hopefully now be explored as the new Director of Public Health, Matt Pearce, who's coming into office on the 1st of July. And we think this is in good shape for him to pick up.
Thank you, John. I'll turn to Councillor Burke next with a question and then come back to Rachel.
Thank you, Chair. Yeah, I note that there are five core priority areas identified here, one of which is female suicide deaths. Can I just, I don't quite, perhaps you could help me understand why this is a priority, considering that male suicide deaths are 3 times that of female.
Shall I come back on that, April?
Yes, John, if you can, thank you.
A very significant proportion of women who take their own lives have been victims of domestic abuse. So it reads across to the violence prevention agenda and domestic violence prevention. So, you know, we have to, in understanding suicide, we need to understand that it's not just one epidemiology, it's a series of epidemiologies that the factors that are in play with younger people tend to be different from those factors with older people, and there are gender differences. There are other issues to do with gender, and always in the past and the present, you know, suicide is a potential issue for older people who have physical illness. So we have to break it down into the groups and see where the interventions need to be focused. So that's the answer to your question. I mean, you're quite right to point out that the male concern at the present time tends to be men around their 40s, either side of the 40s. And we know that seems to be related to a crisis in male identity, which is a comparatively recent phenomenon. So we have to address all these different issues.
Thank you, very clear.
Thank you very much. Rachel.
Thank you, Chair. It was just to recognise John and Councillor Marsh's point about the importance of a bereavement support. And it is, I've just looked through the Suicide Prevention Action Group minutes for the last meeting, which was the end of April. And there is an ongoing action actually on Gary to establish a branch of SOBS in West Berkshire. So there is work underway already. I think it's not been quite as easy as first hoped, but it is an action that is outstanding and ongoing within the Suicide Prevention Action Group.
Thank you. And there's another question from a colleague online. Apologies, I can't read your name on the screen. If you could introduce yourself and then ask your question. Thank you.
Is it Councillor Janine Lewis you were referring to?
Yes, apologies, Janine.
And that's okay. It was due to say thank you for the work that is done with on the suicide prevention group, but it's to also recognise that as we've got a large rural population, we should also be thinking about farmers who fall into the category of high suicide rates and mental health. So can we make the point of including representation for farmers? I don't know how much support they're given by ourselves. In particular, there is the charity RABI, can't remember what it stands for, my apologies, but they would welcome an opportunity for this sort of getting into discussions of how we can support the farmers.
Thank you. John, do you want to come in on that?
Yeah. No, I mean, Councillor Lewis, that's again an important intervention. Again, I've had extensive experience in rural public health in Cumbria and other parts of the Northwest. And it's one of a series of issues that affect but not just farmers, but rural communities, the isolation and the difficulty of ensuring good access to intervention, to support, to care, and so on. The other kinds of things that are important in rural communities are farm deaths from accidents, and not unusually affecting children. A farm is an industrial workplace, and having a strategy for rural health is something which I think we should work towards in West Berkshire. And I know Guyan Pereira, who's currently leading on the intelligence function, has started to do some thinking about how we drill down on the data to identify better where the problem areas lie in the West Berkshire area. I mean, I'll give you an example on the accident prevention. In Sweden, they have an ambition of 0 farm deaths. And they've gone about doing that with the farmers working together on peer inspections of farms. Farmers don't take kindly to external agencies coming and telling them what to do, but they're much more willing to listen to each other if they inspect each other's farms for hazards. So I think there's a lot of work to be done in different areas with the rural community, and the suicide prevention is part of another thing. I mean, it's much harder to provide support to other kinds of groups like gay men in rural areas, which was a particular problem we faced during the peak of the HIV epidemic. Was how do you reach out to men in rural communities where there may be a lot of stigma? So there's other issues, and I think we need to think quite strategically about how you address rural health issues, but in this context, suicide prevention and the condition of farmers. I don't know what the economy of farming is like in Berkshire, but I do know something about the economy of farming in the Lake District and the Yorkshire Dales with small hill farms and the struggles that farmers have to make a living. So there's a lot of economic pressure in some of those areas. But I hope that's helpful.
Thank you, John. Councillor Lewis, has that answered your question?
Yes, it has, and thank you for taking it into a wider context, John. And I would like us to think that we've got a separate agenda to add on to a lot of these groups. It does include the rural communities, because quite often I think we overlook them, and there's nothing ever specific in all of this. And I know I keep reading reports on good old Twitter, and that's where I'm getting my education. So it's a shame we haven't got something that I'm aware of within our own documents. Thank you.
As of yesterday, when I was at the Scottish Public Health Conference, I discovered that we've got to start tuning into TikTok, because that's what all the young ones are using. Us old ones are talking to ourselves when we're twittering. We need to engage with TikTok, and I hope that perhaps we can think about that at some point here.
Thank you, John. We all look forward to receiving your TikTok handle, and we'll be your first followers, I'm sure. But it is an important point to make. How are we constantly reviewing and refreshing how we're reaching our public in kind of current ways, making sure we're reaching everybody. So that's a good point as well. Thank you. April, I'll bring you in with a question.
It was just a comment. Thank you, Councillor Lewis. And I've noted down here that request that you've said, and it's something I'll certainly take away and look at and see how we can really address that, because I know you raised similar issues at the conference, which I'd noticed as well. So thank you for that.
Thank you. Are there any other comments or questions? Councillor Paul?
Thank you. I've got a quick comment and a question. So the quick comment is, by the time a little bit of marketing information, by the time somebody has decided that they need help and advice, they need it now. So, and all that lead up about where support is and where it's visible and where you go for support, it's really, really important, because that's like marketing. That's where people know where that information is. And it's 95% of that. So by the time someone needs it, then they know where it is. If someone needs to spend time looking around, finding advice and support and sitting on a waiting list for 2 years, the time has passed for them. So it's really important that we're able to correctly market the support available, as well as be able to provide that support in a reasonable time frame. So I noticed, and this leads into the question, that within this paper, it doesn't say anything about providing support or looking at the timelines of how support is going to be given. And I also notice in here that it seems to be written for adults, whereas a lot of the conversation today has been around children and young people. Because I'm aware that, for example, Number 5, which is a charity providing mental health across Berkshire, they have an 18-month waiting list already, and they've got over 1,000 people waiting to be seen. And that's just them. That's not talking about CAMS or any other additional services. By the time mental health comes to a point where someone has no other choice but to take their own life, that's the point where I think that we as a system have failed. We need to be having a strategy that engages and is very proactive. And I love the report, but at the minute it's written for adults. There's nothing in there for children. And I don't know how all this comes together, because suicide strategy is more than just people. It's young people and the demographics. And I don't know who the best person is here to answer that, or whether or not it's an action that's taken away to look at the individual strategies.
Thank you. John or Zoe or April?
Well, so I think if that's the case, and you may well be right, that clearly that needs further work. Let's just put it that way. I think we've been trying to bring up to speed something which had been sitting on the sidelines for the last 3 or 4 years. So there's still work in progress here.
Thank you. And April wants to come in on that as well.
Thank you, Councillor Paul. I think you raised a really good point. In terms of, we have lots of information about mental health support on the website, and I know often we are doing lots of social media around it, but I think it is really important to think about how we're linking those two things. And we have the mental health action support, mental health action group as part of the subgroup of this board, and it's how we get that group to link with the suicide prevention action group as well, to make sure that we are addressing those things in a joint way. But to reassure you, we do have lots of information on our website about mental health support. But I think you raise a really good point, especially around children and young people as well.
Thank you. And Zoe, I see you reaching for your microphone, so I'll bring you in as well.
Thank you. And just to highlight that it's very much aligned with the national strategy, and one of the 5 core area of focus referenced in the national strategy is children and young people. So that is being looked at. Thank you.
Thank you. Are there any other questions or points to raise? This has been a really helpful and important discussion today. Thank you. So we'll turn to the recommendations then if there's no other questions. So there's 4 recommendations in the paper that we as a board are asked to agree. So I'll take them in turn and then we'll agree how we vote on them. So the first one, we're asked to approve the Berkshire Suicide Prevention Revised Action Plan. I think there's, sorry, before I carry on, I will, Councillor Lewis, sorry.
Lewis, sorry. It was just to thank you for finding me. It was just to highlight the fact that the VCWB also do a first aid course. It's a mental health first aid course and a suicide prevention first aid course, and it is very much aligned to what Councillor Paul had suggested, that when it matters now, and it helps to train people to recognise the signs and be able to go over. And you're absolutely right that it's the first 2 hours is part of being there that will help that person. It's no point saying afterwards, oh, there's a support group here. They need it there and then. So I'm sure Rachel will share information of the next first aid courses specifically for that.
Thank you. And that's also relevant to the recommendations. So the first one around the board being asked to approve the revised action plan. I think some of the discussion today has highlighted a couple of areas that we might want to ask Zoe and John to take away before we can agree the action plan. Firstly, around discussing with our local suicide prevention action group and getting their inputs, because they're a really vital group of experts in this field. And also looking at, are we clearly pulling out how we're providing sort of availability and support when it's needed at that moment in the action plan, and how it's covering adults and children. So I feel as a board, we probably shouldn't be voting to approve the action plan today, and would ask that those points are considered, and then we can agree how we bring that back to the board at a future meeting, if that's okay. Thank you. Are there any dissenting views to that proposal? No. Okay, thank you. So the second recommendation is that we as a board request a progress report on the development and delivery of the 24-25 action plan and proposal for next year, which does sound eminently sensible to me. The third recommendation is that we request assurance from my organisation, Bob ICB, that the spending plan for all age mental health transformation and service provision, now that the NHS England suicide prevention funding has ceased, is aligned to the Berkshire suicide prevention priorities, particularly bereavement support. So I can't comment on the availability of that budget today as a representative of the ICB, but I do think it's reasonable for us as a board to be asking that question and seeking that assurance. And then the fourth recommendation is that the Health and Wellbeing Board members are asked to also offer support for involvement of their organisations in the emerging West Berkshire multi-agency suicide prevention group that's currently the Suicide Prevention Action Group that we've just referred to help develop and implement the local action plan, which also feels like a very reasonable request as well. So can I suggest we take a vote on recommendations 2, 3 and 4 as a board, and we'll come back to number 1. So I'm going to propose that we take a vote on agreeing those recommendations. Please, can I have a seconder? Thank you very much, Councillor Burke. So all those in favour of agreeing recommendations 2, 3 and 4, please raise your hands. Thank you. All those against? Anyone wishing to abstain? No, excellent. So we can agree those recommendations, and we'll come back on the specific action plan. But thank you, and thank you to you and the team for all the work that's gone into that. Okay, I will move us on to item number 10. I'm just going to check first, do we have Ali Foster online? Excellent. So item number 10 is an update on the Building Berkshire Together programme, which is linked to the Royal Berkshire Hospital Estates Rebuild programme. So Alison Foster is the programme director for this programme, and she's going to present a report for us today.
Hi everyone, thank you. Do I share my slides or do you use them? Which is the best?
Either's fine. What would you prefer, Ali?
Okay, I'll try and share mine then just now. No, I'm having problems.
Gordon can share it for you if that's helpful. He's just going to load it up now.
Thank you.
There we go. Can everybody see that on the screen who's joining us online? Yes, Ali, can you see that?
Yes, I can see it. Is that? Yep. Thank you. Thanks. Next slide. Many of you will know some of the things in here. I just wanted to set the context and background. We've been on the new hospital program since 2019, and we are cohort 4, which means we're full adopters of the new way of building hospitals. So that is called Hospital 2.0. So this means that hospitals will have standardized designs, a centralized process and modern methods of construction. What we mean by that is that they will be built off-site and shipped in and constructed on site. So the standardized process goes right the way through to construction and also sort of contract frameworks, etc. So the idea is that it's anticipated that through this programmatic approach, it will deliver economies of scale and reductions in time. An example of that is that currently it takes on average about 14 years to build a hospital, and the first part of that is quite a lengthy business case process, and then on to construction. This process is looking at reducing that by almost a half to 7 years. So it's taking quite a while to set up that process. So to get to standardized designs and have people from across the country and indeed across the world feed into what good looks like in terms of a standardized design, and to get that approved is just one in many, many, many elements of that process. And also setting up the supply chain ready to start the factory process and build process for hospitals. They're aiming to have that process set up by 2028. And so there will be a lot of hospitals sort of being built with this process from that point onwards. Next slide, please. So in May 23, it was announced that there was 20 billion for the whole programme up to 2031. But you'll remember that 5 hospitals were added, which have the aerated concrete. And that's 5 whole hospitals. So it pushed some schemes out to make room for those because they have priority. So we were given a start construction time of 2031, and funding was aligned to closer aligned to a partial or early phase development on the current site. But since that time, we've been working with the new hospital programme to demonstrate that building a hospital 2.0 on the current site with some of the challenges that we have is going to be extremely challenging. The Trust agreed that our preferred way forward would be a new hospital on a new site, and that was done after some of the items that I'll share with you at the next slide came to light, but also a significant engagement exercise across the patch to look at the solutions for our hospital of the future. Next slide. So to just talk about briefly some of the issues on the site. Hospital 2.0, if we were to deliver exactly the same number of beds and services, would be approximately a third bigger in size than what we currently are delivering from. And that is it's got single rooms, it's got wider corridors, it's got bigger spaces between floors. So on that diagram on the right, you'll see on the left-hand side, it says South Block. That shows 3 levels that we currently have in South Block. And if you have 3 levels in the new Hospital 2.0 compliant block, you can see that it's a lot bigger. So already, if you were to build just a block next to our own blocks, it would involve building in slopes into that, and ramps. We've also been working to understand our geological features that we have under the hospital. Not unusual to Reading. We are on chalk mines, and to try and understand the impact of some of that on constructing on the site. And we've been carrying out a whole site survey on the site. So on the left-hand side, the hospital there, you can see where it's got red on it. That shows that there are a lot of geological features underneath the hospital or potential for them. So to explain, the survey carried out has said that whilst they are there, we will get plenty of warning if they start to appear underground. Because we are monitoring it all the time. It's just, it will cost more and is more complex to manage to build on the site. I've grabbed a coffee shop here to because I'm traveling at the moment, and sorry if there's some background noise. And then on the left-hand side of the site there, we have demonstrated what it would be like to build a Hospital 2.0 feature on just that part of the site. So there's been lots and lots of options developed to demonstrate how difficult it would be to build on the current site, which has led us to look at building off-site. Added to that, those features that are quite big on that site would need planning permission. We are surrounded, we're landlocked, so we don't have a lot of space to move around. We are surrounded by a conservation area and residential area. So there's a whole list of things making it really, really challenging to build on the current site. Next slide, please. So between January and March, we engaged with the public around our criteria survey. So that's the criteria for looking at a new site. So what is it that's important for people when we're choosing our site? And we got a huge amount of responses, and we also, it's also a way of trying to identify sites that we haven't been able to identify through the normal search. So there might be landowners out there that weren't thinking of selling and hadn't got it on the market, and may be able to contact us. So we have carried out that review of our criteria, and the survey has helped us to update some things that were really important to people. So flexibility going forward. Some of you may be aware of the move from Battle to here, and people have said, you know, we need to be thinking in the future of hospitals that have the ability to expand and don't get ourselves in a situation where we're constrained in this way going forward in another 20, 30 years time. So that was something that came out on top, and we're looking to adding that to our criteria. So two sites currently that have scored quite high on the criteria have been identified as Thames Valley Science Park and Thames Valley Park. And we are carrying out more investigations onto the feasibility of those sites. And we'll feed back to you this month the feedback that we received around the criteria survey and how that's impacted on our assessment process for a new hospital on a new site. Next slide, please. We are now also, with that information, starting an impact assessment. So if we move to one of those two sites, and there may be other sites that become available, over the next 4 months, we are carrying out an exercise of what does that mean to the staff who are working currently in our hospital? What does it mean to the population that need to use our hospital? So that's right from, you know, West Berkshire right the way across to Wokingham. We're carrying out some, what does it do in terms of the health inequalities? Does it impact on people who are already adversely affected by health inequalities? Does it push people into having more health inequalities by moving it? So lots of traffic and transport analysis. The top, anytime we talk to the public, the top thing that concerns people is access. It's getting to the hospital. So we've got quite a lot of traffic and transport analysis to do, and we're doing some economic analysis. We'll be doing this through workshops, focus groups, and interviews. And we will also have a survey. So that will be taking place between now and the next 4 months. Next slide. So it's really, that's just a summary of where we are. There was a meeting yesterday, not yesterday, on Tuesday, on the 30th of April with the Treasury. The new hospital programme were presenting to Treasury for a request to increase funding and accelerate the programme on Tuesday. We will not find out how that went for another 2 or 3 weeks. The process is Treasury makes a recommendation to ministers. It needs ministerial approval, and then there's a communication cycle linked to number 10 grid process that needs to happen. So we won't know what the outcome of that discussion was for another 2 or 3 weeks. So we obviously we've put forward that we need resource for a new hospital and a new site, and we're awaiting the funding decision on that. Any questions? And I apologise if you can hear any noise behind me.
Thank you very much, Ali. And also just to note, we've got Dom Hardy on the call as well, who's the Chief Operating Officer at Royal Berkshire, so might be able to answer any questions as well as we go. Ali, I just have one question myself, and then I'll open up to the board. How can members of this board help you with the kind of the impact assessment and the further work that you're doing around the impact of moving the site potentially?
That's great. So we're about to launch ways in which people can get involved. I will say there have been members of this board and the scrutiny committee who have come and attended the site and done site tours, which has been really, really helpful both for their understanding, but also for us to understand how we might engage with and link with people. So I'd encourage anybody who's who wants to have a site tour and understand some of the issues to come and do that. We're open for that, and they've been really helpful. But also the engagement with the public at this stage, it would be really helpful if you are attending groups or workshops. We quite often see, on social media, pictures of people who've attended groups that we never knew, or events that we ourselves didn't know what was happening. And I think it'd be really great if we were to know more about those and come with and give people information to ask the right questions and feed that back, because you guys are all representing your community. So if there's any way at all of us linking to those, I mean, we literally go to anything that we're invited. We went to a parish council AGM in your patch only a couple of nights ago, and it was attended by about 60 people. So really, really happy to come out and talk to people and hear what they've got to say.
Thank you, Ali. And what's the best way to contact you and the team?
So we've on the website, but we've got my email, so alison.foster@royalberkshire.nhs.uk. That'd be great.
Lovely. Thank you very much. I will go to Councillor Marsh for a question.
Well, it's a sort of comment and question, Chair. Thank you. Thanks for that report. Very interesting. I just wanted to say something about transport. You say that travel and transport is a key part of what you're looking at. Can I ask you that you will please look at a radical approach to this? One of the problems with the current siting of the hospital is, for example, from here in Newbury, you've got to get a train and then a bus to get there. And if you try to drive, you're going to get caught in traffic, and then there's no room in the car park when you get there. But time and again, we've seen that the answer to this is not to build another vast car park, which will get full in no time at all, will cause more problems and arguments about the fees, whether the staff should be paying, which they shouldn't in my view, and so forth. Now, clearly some people will need to drive to the hospital, but many people would use public transport, many more people. For a lot of appointments that you have, you can use public transport if it's convenient. So, for example, from Newbury, if there were, say, a bus from Newbury bus station to the hospital, I'm convinced a lot of people would use that. Would just be so much more convenient and easy than driving and then trying to find somewhere to park. So it's an opportunity. A completely new hospital is an opportunity to address this, and hopefully with a sort of fresh approach, not just repeating the problems that we've had at the current hospital and at other similar sites. Thank you very much.
Thank you. Ali, did you want to comment on that?
Yeah, so there's a couple of approaches to this. So firstly, if we get a brand new hospital on a new site, we're looking at an 8 to 10 year opening time. So it will take that time for a business case and construction. Meanwhile, we are trying to look to utilise things like the West Berkshire Community Hospital more. That's part of our strategy in terms of what does the new hospital actually need to contain, and what can we position and locate closer to where people are. So that's the second thing, and the third thing is just keep those suggestions coming, because that is exactly the kind of comments that we need. So it's part of the impact assessment is to look at what is the impact of moving it, but what can we do about that? So there might be things that mean it's adversely affecting some people, but what are the ways in which we can address that? So what we call mitigate some of those things. So thank you very much. Those things are really, really helpful. So keep them coming.
Thank you. And John Ashton, do you want to come in as well with a question?
Yeah, so I'm not alone in having a lot of concerns about the way this has been approached, because the person who frames the question determines the range of solutions. And it seems as though the question's been framed about replacing a hospital rather than about what kind of health system is going to be required in 20, 30, 40 years' time. And, it all follows on from that. I've been attending the workshops that have been held in this, and have been pushing the group that are working on this to start being more imaginative about the future. My public health report for West Berkshire will be available hopefully in June, and that gives some indications about the changing nature of the need and demand for health and healthcare in West Berkshire and in the West Berkshire area generally over the next period. But what I would hope my successor here will do is start focusing ahead on 2040. My son, who's the Director of Public Health in Liverpool, has recently published a report on Liverpool 2040, and there's increasing concern to focus on that. We've got an aging population, increasing demand, and a number of other factors which are really important. For example, the desire for people to die at home rather than in hospital. During the pandemic, the proportion of people dying at home exceeded 50% for the first time. Something like 80 or 90% of people who are at end of life stage would like to die at home. But the reason why it doesn't happen at the moment, and why they have repeated hospital admissions, which are expensive and take up beds and so on, is because there isn't confidence in the community health system to provide support to families, to care for a dying relative at home in the last months and years of life. I think we need to be looking at scenarios rather than one scenario. It seems to me that at the moment, what we've got is a scenario of replacing a hospital with a bit of cap doffing to prevention. What they'd done in Finland 40 years ago was to put a ceiling on the proportion of the health budget that could be spent on hospitals. And they've created a system in Finland which is based on primary care and community care and public health and prevention. And the primary care centres have beds. There are a range of facilities there, and it works very well. And they're a country which has a similar gross domestic product to ourselves, but they have a very resilient system to cope with it. So between the business as usual, replace a hospital with another hospital that's similar, and a transformational agenda like the Finns, the middle option, which may be a transitional stage, would require saying, well, if we work towards a strong primary and community care system and invest heavily in prevention over the next 5, 10, 15 years, what size hospital would we really need then? And that's what we've been trying to get people to start to think about. Just my final note is, in other parts of the country, there's now a lot of interest in an initiative that's called Health Spaces, which is where department stores and other buildings are being re-provisioned as part of the health services in town centres and similar, that are accessible to people. I mean, addressing the Newbury question about having to slog over to Reading, having a network of facilities that are accessible to people, and the changing practice. I mean, for instance, there's recently been reports about a medical approach to treating lung cancer. The advances in pharmaceuticals that mean that in future treatments may be medical rather than surgical, and so on. We just don't know half of what's coming down the track. So we need to keep an open mind about what's appropriate for West Berkshire, or otherwise what will happen is there'll be a white elephant created that won't be fit for purpose in 20 or 30 years' time. So this isn't just my opinion, it's shared by the officers and councillors over in Reading. So I think we need a more comprehensive discussion, I think.
Thank you, John.
Thanks, John.
I'd make some comments as well.
Yeah, I was just very, very, very quickly. It may well be that we think about. So I'm talking about the hospital, and the hospital comes after a significant multi-year transformation plan and program. We are engaging with the wider system on those discussions. So I'm sorry that doesn't come across here in this, because I'm talking about the hospital, but 100% we have those discussions going on, and it might be worth sharing that with the committee at some point in the future around the discussions that we're having. So we're looking at virtual hospitals is taking off. How do we look after people at home? How do we support people with frailty, for example? And there's a whole list of things in terms of transformation that is happening and being planned right now to help us right-size the hospital. So I haven't talked through the process here today of how we right-size that hospital, but there is one, and I'm more than happy to come back and talk about that and describe that in much more detail at a later date.
I think that's important, because the headline here seems to be replacing one hospital with another hospital.
Thank you, Ali. I'll add to that as well. So clearly there will be a need for an acute hospital. There always will be. And we need to make sure that that is the right size, but also of a size that gives us viable sort of economies of scale to live within the financial means and the financial envelope that we have as a health service. However, there is a very clear commitment to look at the model of care that we are providing across our range of providers. That was very clearly signalled in our primary care strategy that we discussed at the last board here, and work towards a more proactive and preventative model of care. In terms of this specific project, kind of once we get clarity on the capital financial envelope that we've got to work with, that will help to determine what those sort of immediate next steps are, because clearly there's a range of funding, and the options and opportunities that presents for us as a system will depend on the funding that's made available by Treasury for this particular programme. But it absolutely is a kind of a system programme of work, of which Ali's talked today about the bricks and mortar part of it, but that's one part of a greater programme. And as Ali said, we can value a discussion around if at the moment the emerging form of that programme doesn't feel like it's hitting the mark for yourself, John, and other colleagues. We would want to discuss that further, of course. Thank you. Dom, I can see you want to come in on that as well.
Yeah, I really welcome John's comments, and I actually agree with them. I think what I'd want to just frame though is a conversation away from the kind of renewal of acute hospital services back into what's going on right now. So even beyond what you've described, Sarah, the place of Berkshire West, with West Berkshire at its heart, is already engaged on a really enormous programme of work to move services closer to patients, whether that's directly in primary care or general practice, or even further upstream into prevention, whether it's around virtual services that see people in their normal place of residence, whether that's a care home or their own home, whether that's outpatient services, not just moving to spoke sites like the West Berkshire Community Hospital down the road from me, but also into general practice as well. That process has already begun. And what Ali is rightly describing is our current process of seeking to acquire enough money to replace the current set of infrastructure that we've got on the Royal Berkshire Hospital site that largely is not fit for purpose. It wasn't fit for purpose for 20th century healthcare, and it's certainly not going to be fit for purpose for 21st century healthcare in large part. We've got buildings that date from the 1820s. So, that John is both absolutely right, and also I'd want to point out that we need to do more than one thing at once here. The hospital building work and the bid that Ali's described sits within that wider context. And if we need to work harder to explain more clearly how that clinical services strategy hangs together, and how even we could use the kind of bid for a new hospital development to support that kind of moving of patient services closer to patients, then we absolutely should do that. But I don't want anyone to be under the illusion that we're not going to do more than one thing at once. We absolutely do want to get the money to build new acute hospital services. We definitely do need that. And in doing so, to Ali's point, we want to make sure we build the right type of hospital to service the need of people who will need hospital services. But for those who don't need to come here, we absolutely want to make sure we've got the services in place that avoid them ever coming to a new hospital site where possible.
Thank you, John. I'll bring in Councillor Lewis.
Thank you. Some really good discussions going on here. Just want to bring you back to the comment Alison made about getting more community engagement. You mentioned that you'd gone to a parish council. I would be interested to understand which one, so I know who to approach to figure out how they got 60 people in the room. And I would welcome us being able to roll that out to other parish councils, because I think the feedback from across West Berkshire is important, especially as Councillor Marsh mentioned, travel is going to be an issue for people on the far side of West Berks. They're not going to want to go to that hospital. It might be the only one that they can get to. I don't know what hospital facilities there are on the other side of the borders. But certainly for myself in Tilehurst, I'm not that far from Royal Berks. It can sometimes take me up to 2 hours if I'm relying on public transport. So back to the initial request, which parish council? Because I'd love to approach them.
So Stratfield Mortimer, and somebody there mentioned that they knew you. The assistant clerk there says that she knows you. But yeah, they had speakers coming in. It was the parish council AGM. So I was impressed myself. So yeah.
Fabulous. Thank you for that.
Thank you.
Thank you. And Ali, it might be worth sort of mapping out your current sort of engagement plan and where that's reaching, and sharing it with officers and councillors here as part of that wider. How do we make sure we're reaching everybody equally?
Can I also just say that it is worth having a look at both the website and our social media, because you'll see on there we put pictures every time we engage with the public. We're really conscious of sharing what we're doing and who we're talking to. So you will find information on our socials as well about who we're engaging with. But I will more than happy as well to share our comms plan going forward too.
Brilliant. Thank you. That's really helpful. I'll bring in Councillor Brooks.
Thank you. I think residents would expect and hope to see a new hospital provided in the fullness of time. And we certainly are talking about a long period of time, aren't we, from funding to development? I think you said 14 years to develop a new hospital. I was fully in support of what you said in terms that there will always need to be a hospital for acute diagnoses. So although Mr. Ashton makes a very good point about we live in a changing world and we live in a time where lots of treatments are coming online, and it's wonderful to see, I wonder if we shouldn't be pressing on to identify a site. What you then build on that site will change over time, but I'm sure members of the public throughout Berkshire, certainly Berkshire West, get my terminology right, would wish to see this project, get some acceleration on, given the timescales we're already talking about.
Thank you. Ali, do you want to just comment on the timescales? Because I know this is something that has been being sort of a very high profile, pushed for quite a long time. Some of the discussions with Treasury around funding and availability, I think, have impacted some of the timelines. But just to reassure Councillor Brooks, the work to identify alternative sites, as Ali's outlined in the pack today, is very much pushing on at what feels like a realistic and reasonable pace. But Ali, would you like to come in?
Yes, so at the moment we're scheduled to start construction in 2031, but a lot needs to happen before then. So we need to produce our business case. We need to look at what that hospital needs to look like, and there's some enabling work that we'll probably need to do. We'll also have to secure the land and make sure that it's ready to start that construction. So in fact, it shouldn't be 14 years from now, but I can't guarantee that. But that's the time frame that we're currently working to. We are also working to try and pull some of that forward if it's possible, so that our construction time is linked to funding rounds at the moment. So if there was availability or opportunity to bring that forward, we will be seeking to do that. But at the moment, it's starting construction. That's what they call spade in the ground in 2031, which actually isn't that far away in terms of the work that needs to be done to get us there.
Thank you. Are there any other questions or comments from members? None. Okay, well, thank you very much. Thank you for joining the meeting. That's been a really, really useful and insightful discussion, and we look forward to the next update. I think these are fairly regularly scheduled, aren't they, on our forward plan? So thank you very much, Ali, and thanks, Dom, for your input as well. Thank you. So I'll move us on now to item 11, which is the cost of living update. I'll invite Sean Murphy to present this item.
Thank you, Chairman. So this is the latest, as the board will know, in a series of papers, and I think it's fair to say that the board has very much become the oversight body for this work. And I welcome that, because clearly all of the feedback that we're getting and some of the discussions we've had previously show the impacts basically of financial hardship on health. So what the paper really sets out is the latest position in terms of joint working between the council, between Greenham Trust and our voluntary sector partners. Some of the feedback that we've had from those partners recently, and you can see that some of that feedback again draws on issues around health, but also draws on issues around things like debt advice and increasing demand, despite the fact that some of the high level indicators such as inflation have improved significantly since we first started discussing this. So the report also sets out basically how the spend was allocated from the last year's household support fund, and you can see basically the shift in the summary at 4.3, where over 350,000 of that, or around 350,000 of that, was delivered basically in partnership with the voluntary sector, which was a big change basically in terms of the approach that we had. Going forward, we have been awarded, and it was just announced late in March that we were awarded £694,000 for household support fund for West Berkshire for the period April to the 1st of October. So that was excellent news, and we've managed to get together, because we have an established methodology for working with our partners. We've already managed to get together basically a set of proposals around spend, and in fact those proposals have been signed off today by the relevant portfolio holder. But what I am now able to tell the board is that those proposals will include basically assistance for food and energy as before. So these are for low amount payments, basically, which would be quite difficult for the councils to administer, quite often £30 or under for immediate need issues. There will be more funding put into the essential household supports goods scheme, which includes the provision and replacement of things like cookers, beds, white goods. There will be support for those in terms of food support for those in emergency accommodation to provide access to hot food. There will be additional support basically for discretionary assistance. We are providing support within terms of the school holiday meal provision. So that will be an allocation for 4,200 young people over the summer holidays for 4 weeks. There will be, again, targeted support for pensioners and those young carers and those leaving care. And then finally, a sum of around £200,000 has been set aside from the fund where people will be able to make applications directly to the council for immediate support. Just one other thing to add is that we have allocated again a sum of money, £50,000, to go into the joint fund with Greenham Trust. With Greenham Trust, and I can confirm that that fund now has issued grants of £209,000 already to local organisations across a range of matters, including provision of immediate help and support through to debt advice. So we will be taking that forward because obviously it's an effective way also of increasing the pot, as it were, because of the match funding and the appeal that goes with that. If I can just return very quickly to I suppose my failings basically to complete the action plan. To be fair to Gordon, it wasn't for the lack of trying to get the information, but I have been away for a while and I've come back and it's been quite busy. So just picking up at action 244, the meet with Matt Hensby to discuss support that is available. So we now have, in terms of the local coordinating group, we now have a representative or representatives on there from Sovereign Network Group. In terms of the Action 246, the Public Protection Service involved in targets identified in the report, I can say that basically this is now embedded in the work that we do. We very much recognise as a service the impact between financial problems and health. We see it both in our work in housing, but we also see it in our work with victims of fraud and crime, where basically the impacts can be severe in terms of health. Life-changing. And then the final action at 253 around donation items. I think it's fair to say that's probably a work in progress, but that's kind of the update. Just to sum up, I think the view is that there are still a number of people out there who are really struggling. It is affecting health, but we now have a well-established partnership working relationship basically to provide targeted support for those individuals. I'm happy to answer any questions.
Thank you very much for the paper and summary and for covering off those action points as well. And it's good to have you back. This is obviously a really important topic. We know the impact that concerns around cost of living have on our residents' physical and mental health. So it's really good to get this update. Are there any questions or comments from anyone on the board today? No. Really positive to hear the confirmation of the funding as well that's coming through. I think that sounds like it's going to make a really, really big difference. So there's two asks. First, that we note sorry, Rachel, we've got a question online. Thank you, Gordon.
Thank you, Chair. It was just more a comment really to support the points that Sean has made and just reflect that the opportunity for the voluntary sector to engage and really move forward with some key deliverables has been very well received, and it was just a thanks really.
Excellent, thank you very much. And John?
Thanks for that. Yeah, that's very interesting. I think I've mentioned here before that when I was working in Northamptonshire previous to this, and the public health team had the household support fund, and you've mentioned the health aspects of this. So I don't know whether going forward, we could have a bit more involvement in that. In Reading, we've developed that over the last few months, and for example, we've been funding milk for nursing mothers. You know, there's been a trend towards poor women stealing milk from the shops. So we've actually had a scheme now in place in Reading to be able to provide that for nursing mothers, just as an example. But there are other things that we could possibly be exploring over here as well.
Thank you. Sean, do you want to comment?
Yeah, I mean, it's an interesting point actually. As you were talking about that, I was thinking about. So we have this very effective, I think, now working group in terms of partnership working, but actually probably the one gap on there is actually public health input, and maybe going forward, I think maybe it would be helpful to have public health input into that group and attendance of that group.
Yeah, I'm sure that would be appreciated by Matt Pearce when he takes up his role.
Thank you. So we'll note that as an action then for Sean and John in the meantime to have a discussion and confirm public health involvement in that group. Thank you.
Thank you very much.
Thank you. Any other? Got everyone? Okay. So we're asked to note the report and the sponsor partners to date. I think I'd probably take that a little bit further. And Sean, is there anything you need from members of this board to help you with this?
Only really to say, Chair, that I mean, if anybody has got some, so this is a developing approach that we're taking, and we would very much welcome any thoughts that people have basically about further targeting in effective ways and things like this to provide support. So we have the fund. We don't know whether there will be any fund going forward, but it's not all about money. As everybody in this room will know, it's all, you know, it is about other levels of support. You know, when we talk about issues of financial hardship, we talk very much about peer support, and we talk about basically places where people can gather and support and receive that support. So any ideas, welcome. Anybody that wants to attend the group, that they're also welcome. Yeah, no, thank you for the support of the board.
Thank you very much. So we'll note the report. John, is that a follow-up question or is that a lingering hand?
It's a lingering hand. I apologise. Yeah.
And we're also asked if we as a board would like a progress update on this. I don't think we need to vote on this, do we? But we can agree that I think it's important that we do get a further update and see how the impact of that, the funding, but the wider considerations are benefiting our residents. So let's take an action to agree a suitable time for that to return to the Health and Wellbeing Board. Excellent. Oh, Rachel, would you like to come in with a final?
Yeah, sorry, Chair. It was just for the action, could any attendees be forwarded to me as I clerk that meeting? The partners meeting,
yes,
one. Thank you.
Oh, Sean,
actually, the one thing I did mean to say was that I really do want to place on record my thanks for Rachel and for Gary as her predecessor for all of the work they've done to get this off the ground. Thank you.
Thank you, and very much noted, and nods around the room as well. Thank you very much. So if there's no other comments, we will move on to the next agenda item, which is item 12, the Health and Wellbeing Dashboard. And I'm going to invite Guyan Pereira to present this report before we open up for discussion.
Thank you, Chair. Good morning, all. Can you see my screen at the moment?
Yes, we can. It's not in presentation mode, but we can see.
Yeah. Okay, that's great. So I'm going to give you a bit of a background first about the Health and Wellbeing Board dashboard, and then going to present some of the particularly on the 5 areas we're working on. So I've been working with colleagues in West Berkshire, April, Zoe, and with the steering group in order to design the Health and Wellbeing Board dashboard. And there are 5 priorities. So I'm going to go through each of the priorities. And then, for example, the first priority is about reducing the variation in health in the most deprived 2 quintiles and with average West Berkshire. And the second priority is about just a focus on the most needed population groups like patients with dementia, rough sleepers, and look at the progress of health outcomes. And then the third, fourth, and the fifth health outcomes, mainly about children and young people, their health status and their well-being, and also the adults health and well-being. So before I talk about the first priority, I just want to share because the first one priority is about the reducing the the variation in health between the most two deprived quintiles in West Berkshire. So you can see the dot represent the areas of West Berkshire, the most deprived areas. So there is Newbury, Greenham, Thatcham, and then there's Hungerford, Lambourne, and then areas closer to Reading. There are lots of dots you can see. So for me, there are like two kind of deprivation here. So one is urban deprivation, where there's Newbury, Greenham, and Thatcham. There are beastogenic environment, the chicken shops causing the health status or less life expectancy in those areas, or there are lots of lifestyle risk factors, high prevalence of lifestyle risk factors on those areas. And then there is rural deprivation. For example, people living alone, the farmers, and there's no access to digital, there's digital poverty in those areas, and also no access to nearest shops, supermarkets, etc. So first, I'm going to give you a bit more information about those, the 5 priorities, and the starting of the first priority is to reduce the differences in health between the groups of certain people. And here we are looking at the prevalence of certain health conditions, particularly long-term health conditions. And what the estimation suggesting is that the two most deprived quintiles should have double the prevalence of average West Berkshire. So you can see the hypertension, obesity, and diabetes. The prevalence in the most two deprived quintiles is higher than the West Berkshire average. And you can see similarly the COPD, the prevalence is higher than the West Berkshire rates. However, the CHD, atrial fibrillation, and stroke are all caused by risk factors like hypertension, obesity, and smoking. And we all know those areas are high, the two most deprived areas have high prevalence of smoking and obesity and hypertension. However, the recording or the diagnosis of atrial fibrillation, CHD, and stroke is low in the most two deprived quintile areas. And those are the probably 3 conditions we want to identify more in those areas. And then moving into the other 2, the lifestyle risk factors. Here I'm talking about the smoking. And we know smoking is really high among the 2 most deprived areas in West Berkshire. And for example, here we can see about the smoking prevalence among the two most deprived quintiles is 20% compared to the average West Berkshire is just around 11%. So significantly high rates of smoking in the 2 most deprived quintiles in West Berkshire, and that causes smoking is the single most kill or the cause of for lung cancers and most of the cancers and the cardiovascular diseases, etc. And then the second factor, I'm going to move into obesity. And here we are looking at the rates of obesity in the 2 most deprived areas comparing against West Berkshire. And we can see roughly about 14% of the people living in the 2 most deprived areas are identified as obese. And then the average rate in West Berkshire is around 8%. Again, obesity is also a risk factor for most of the cancers and also the coronary heart diseases and cardiovascular diseases. So you can see the 2 most, the risk factors, the smoking and obesity are prevalent in the 2 most deprived areas. And that's why, the beastogenic environment, etc., causing the variation in life expectancy where you could see in this particular the slide. So you can see on the variation in life expectancy in the most deprived and least deprived areas. And if you look at, for example, in England, you can see the England rates at the right of the 2 lines at the top. So particularly unfortunately, the variation in health or the life expectancy is actually the gap is getting larger and larger in England. For example, right now, the variation is about 10 years gap between the most and the least deprived areas for men. And then for females, that gap is about 8 years. However, West Berkshire, the story is much more better and even better in terms of the trend, and it has been declining since about 2016 to 18. And the current rate for males is around just over 4 years. And for females, the variation in that life expectancy between the most and the least deprived is about 3 years. So in order to reduce this life expectancy difference about 4 years, the areas we want to target is, of course, the two most deprived areas, and plus the targeting the most, the big killers, the smoking, obesity, and the obesogenic environment, and these kind of there's health lifestyle risk factors, plus the wider determinants of health, that is improving the education, the improving employment outcomes, and then the structural areas like air quality and the housing conditions, etc. So moving into the, sorry, I can't see any hands if there are any questions. So moving into the next.
I'll bring them in if there are. I'll let you know.
Thank you, Sarah. So moving into my next slide, again, this is one of the priority areas. Particularly, we want to focus on the services who we need most. For example, patients with dementia. The reason I displayed this slide, you can see the diagnosis rates in England is about 62% for dementia. For example, there are public health organizations like Public Health England or UKHSA. They diagnose what should have been the prevalence of dementia in a particular area. However, there are roughly about 2,000 people with dementia in West Berkshire, but only about 1,200, or just under 60% of the people are diagnosed with dementia. So it's really important. We need to work with the primary care services to improve these diagnoses, and early treatment will, improve the quality of life for those patients with dementia. So that is, again, an area where we actually can support and improve the quality of life for those people who need it most. And then I also want to talk about the rough sleeping, and because the numbers, particularly you can see around 2021, just after COVID or during COVID, the numbers have gone up to very similar to the levels of England at the moment. So we only have the data until 2022. You can see that at that point, there was a significant increase from 2021 to 2022 in terms of the rough sleeping. Again, there are various causes for rough sleeping. Again, the unemployment, and then the poverty, and also people with mortgages, for example, losing their jobs, and then that causes people moving into rough sleeping, and also social circumstances like divorces, etc., causing people moving into rough sleeping. So again, that is an area we need to address as well. And then the third area, we want to help our families and children. Again, Professor Marmot, one of the things he said was, we want to give a good start to our kids, children, and young people and families. Again, when you talk about the early years, we need to think about the -10 months onwards. That's about from the start of the mother, the pregnancy, etc. And so here we are looking at, particularly we are focusing on hospital admissions for children aged 0 to 4. This is an indicator for children's mental health and the environment, the domestic violence of the parents, and then the negligence of the mother causing the child to go into unintentional and deliberate injuries. So roughly, we can see our rates are just higher. It's not statistically significant. However, our rates are about 107 per 100,000, per 10,000 children, and the England rates is just nearly 100 per 100,000 population, about 104, 103.6 per 10,000 population. So again, the key point here is that there's a small community groups, small number of families contributing to these unintentional and deliberate injuries, and that is an area, it's a risk factor for lots of other conditions. And also long term, these are the children going into care and mental health services, etc. So it's really important that we need to address these areas. And then the 4.2 is about rate of children in care per 10,000 for under 18 children. And here we are looking at the England rates are significantly higher than the West Berkshire rates. For example, you can see, even though rates are significantly higher in England, our rates, particularly between 2021 and 23, has gone up significantly. But for me, the key point is we want to prevent children going into care first. It's not just economic argument, but also the evidence suggests that there's a recent Lancet paper. They actually looked at the outcomes for children in care against children who didn't going into care, etc. So those two communities, the two cohorts, when you look at it, what they observe is their education outcomes, their education attainments, the GCSE results, the A-level results, and then the rates of violence is significantly high in children in care compared with the children who are not in care. So it's really important that we actually, first is a prevention is important, and then the secondary, we want to make sure that those outcomes are actually improved for those going into children in care. And then I also want to talk about some of the local services. And here the 4.4 is about mental health service team in West Berkshire doing a really good job in relation to preventing and focusing on mild and moderate anxiety and depression. So they are working with schools and they identify the children who needed most in terms of the low levels of anxiety and depression. And here we can see in the last couple of quarters the numbers referred to mental health service teams. So varied about 187 in the quarter 4 of 2022-23 and gone down to the lowest number in 23-24 in the quarter 2. However, you can see generally that particular team has achieved the target. You can see on the dash demonstrate the target for that particular quarter. And then not just the referrals we want to look at, we want to also look at what their outcomes. So here the various measures that we've looked at, and roughly those who actually use the services, mental health teams, about roughly just over 90% of those children who use the services have achieved their good outcomes needed so that their education is improved and also they get on very well with other students and colleagues. So I'm going to move into the last couple of slides, and these particular couple of slides, we are going to look at the health and well-being of our adults residents. And here, particularly looking at the mental health status, serious mental illnesses, that's severe depression and schizophrenia, etc. There are roughly our GP colleagues or primary care colleagues identify 1,012 residents with severe mental illnesses. That's roughly about, as a percentage, about 9.9%. So again, it's when you look at the estimations, it suggests that there are roughly about 1.2 people in West Berkshire adult population is estimated to have serious mental illnesses. So we need to improve our diagnosis for those severe mental conditions. And then here we are looking at, again, depression, and year on year, and I want to look at the prevalence of depression. And currently there are about 14% of our residents diagnosed with depression. And particularly, I want to look at the early years between 2013-14 to 18-19. When you compare against England, our rates were low. It doesn't mean we are good. What it means is actually we are not identifying enough patients with that particular diagnosis of depression. However, the 2019-20 onwards, you can see again in West Berkshire, the diagnosis has improved so much, and now our rates are higher than the rates of England. So now we have identified the patients, and it's really important that we actually provide good services and working with the social care services as well as the primary care colleagues to give a good support for those patients with depression. And then finally, talking about dementia early and also the rural deprivation, one of the risk factors for dementia, etc., and employment, and also is loneliness. And here we are looking at the rates of loneliness in West Berkshire, and we can see about the 17% of our population is they have informed us they are lonely, and it's significantly lower than England, which is around 22.3%. But it's very important that 17% of our population, they are the ones who are at risk of become suicide, and then dementia, particularly among the older people who are living alone in their homes, and they feel lonely and they need support for, in order to manage their health conditions, the comorbidities, as well as the other risk factors like suicide as a result of loneliness. So I'll stop at this point, and these are the kind of my key themes, but in the Health and Wellbeing Board dashboard, there are over 30 indicators, but I didn't go through those 30 indicators due to time limitation. Thank you very much.
Thank you very much, Guyan. That's really helpful. If I provide a little bit more context around this and then open to questions as well. So obviously, as a Health and Wellbeing Board, we have our Health and Wellbeing Board strategy and the joint strategy across Berkshire West. And locally, we've got an awful lot of groups and individuals working really hard to make sure we're delivering against the different priorities within that strategy. the aims of this dashboard is for us as a board to then look at, well, what impact is that having? How are we assured that the work that we're doing is improving things for residents in these really key areas? And also, it may eventually start to direct how we spend some of our time in this board. So where do we think we need as a board to dig further into the detail of, are we delivering on that part of our strategy or not? What extra help might we need to, or focus might we need to give to some areas versus others that seem to be going on the right trend? So the dashboard was born from that conversation through the steering group that Councillor McCrow and I lead on behalf of this board, and this is where we've got to with the dashboard. So the aims of today isn't necessarily to go into the detail of every single indicator. We don't have the subject matter experts in the room, and Guyan presents the data, but won't necessarily be able to answer all the specific questions on the data points. It's more to get a steer from this group of, does this seem helpful? Do you have any comments or questions on the formation of the dashboard? And then hopefully soon we'll stop talking about creating the dashboard and start using it to inform the work we're doing in a hopefully kind of progressive way. So I hope that's helpful context. I'll bring in Councillor Burke, who had an initial question, then come
Yes,
to
thank you, Chairman. Very helpful context setting there. And I have a couple of general points or questions. The presentation we've just seen is not the same as what we've got in our packs. So I don't know whether
I'm sure we can circulate the version that Guyan's just gone through.
Yeah, talking about our agenda pack should be as comprehensive as possible.
Yeah,
to enable a valuable discussion in this forum. And I also have a concern about the timeliness of some of the data here. So, for example, 3.3% of children being reviewed under the ages, etc. Figures for 2021. If this board is to scrutinise and respond, indeed, adapt the strategy and monitor the strategy against reality, these figures are 3 years out. So, what value are they?
Thank you. No, that's a really relevant point, and I don't know if Guyan wanted to come in on this. Sometimes we are working within constraints of national data timeframes, and where possible, that. But Guyan, do you want to?
Yeah. Thank you, Chair. Thank you for the question. Yeah, so one of the key issues is some of the data is coming through our local data sources, so where there's literally only like 1 quarter difference. However, that particular one, 3.2 children in care, so the data is coming through the national sources, and the latest data at the moment is 21-22. So we will try and update when the data is available. I'm sure in the next month or two, that particular data, so we will get the 22-23 data. But we will probably have to wait for another month or two for that. Thank you.
Would you like to come back in on that?
I'm not wholly reassured. It's, data that's even 2 years old is of little value, really, isn't it? I think we kind of. Yeah. I don't have an answer, but I think it's absolutely vital that we have up-to-date data, not just our children, but our whole population.
And I think that's a valid point for us to take away and see if this data set isn't giving us the timeliness that we need. Can we request something in addition to that? Or excellent, thank you. I'll bring in Heather next, and then
yeah, one of my questions was the same, but we have some of that data locally that we report on monthly. So I think some of that data should be available anyway, maybe not necessarily against national data all the time, but some of it. But the other thing I'm trying to think what I was going to say. Yeah, I'd like to see some more granular detail, particularly around those most deprived areas, and how how this board is then going to target its resources into actually improving those particular areas, the worst affected. Guyan talked about particular areas around Newbury and Thatcham, and then the rural areas. And actually, we need to focus in on those, and it's how we're going to do that.
No, I think that's a good point, and it's getting the balance between what we as a board look at and what we expect the subgroups who are working in those areas to be looking at, and then assuring us as well. So we'll take that away as a consideration. And I think April might want to come in on that particular point.
I think that's a really good point that you've raised. And I think certainly in public health, in terms of our interventions, to assure you, we're always looking at putting our interventions in those places where we can see that there's more inequalities. And just to highlight the cardiovascular disease NHS Health Check programme that we've just launched in West Berkshire, that is absolutely doing that. So it will be taking the intervention to where we know the need is most. So we do that. But I think what you raise is important in terms of these data sets, that we really do dig into them as where we're seeing that there are issues. We use that data to really focus in our attention on what we're doing.
Thank you. Anne-Marie, was your point relevant to this? Yeah, I'd bring you in now then.
Thanks, Sarah. It was just to say that we, as Councillor Bullock and Councillor Codlin have raised, we have got verifiable data on some of this information. There's no reason why that can't be shared. So I think it's worth that cross-check back into the local authority if it's data you believe that we should hold. I think one of the other things that is a major source of frustration for me is when you have a single data set that references different timeframes for different elements of the data, because I think we're used to working with this data all the time, but I think it can cause real significant confusion to some people that are reading it when you're comparing essentially apples with pears. And I think the other thing, and it may need to come with a health warning on this data in particular, generally what we've seen across the board is the data picture post-pandemic is significantly different to the data picture going into the pandemic. And when a significant part of this data set is capturing that first part of the early pandemic, then the world is probably even more significantly different than the trends on the graph would suggest. So I think there needs to be a health check, sort of a warning on the front of this, just to capture that. Thanks, Sarah.
Thank you. And some important points there for us to take away, particularly around the standardisation of presentation and being able to use other data sources from within our organisations if they're not part of the national data set. I'll come to Councillor Poole next.
Thank you, Sarah. It seems a bit of a topic following on from Dominic and Heather about the same piece about data stats. So a couple of things. I noticed that we're looking at different dates and we're also looking at different data sets. So I noticed that Frimley's part of Surrey, but yet we're getting data from them in this graph. So it'd be lovely to see West Berkshire data from West Berkshire hospitals. I don't know the overlapping areas and where people's data is. So that could be a question there. And the other piece that I noticed is that when you have one health condition, you usually have others. So then there's a general trend. So if you have X ailment and you get put on certain meds within a defined period of time, you can expect certain things to happen. So this is about predictive analytics. Now, my training is in predictive analytics. I'm an applied mathematician by training. I know that when you're looking at data sets in isolation, you can form one assumption, one conclusion. Whereas when you're looking at data sets as a whole, where you look at where people come from, what their background is, you actually get a bigger picture. And by that bigger picture, you can attribute a more accurate assumption, a more accurate conclusion. And if what Anne-Marie has said is accurate, and I completely believe it is, because I'm a big fan of her stats and her numbers, then if the post-COVID world is different, we need to be looking at some predictive services there to understand what we need to be doing differently to support the members of our community now, based on today's data, rather than based on historic data. So that's a piece in there. I think I've just allocated a whole load of work to someone else to do in terms of understanding the demographics and what needs to be changed there.
No, thank you. That is a helpful steer. And given your expertise background, it might be that we pick your brain a bit further on some of that as well, if you'd be happy to do so.
I do comment at this point that my training finished about 10 years ago, so I'm a little bit out of date, but I'm happy to help where I can.
Thank you very much. Thank you. I'll come to Councillor Brooks next.
I'm sorry to repeat some of the points made, but if you are looking at information 3 years out of date, you're in danger of taking action on data that is just not relevant now. So I was really pleased to see the dashboard. I want to see more of them in this authority, but I feel their impact is lost because of this. Some of it is up to 23, and that is relevant, and we can take action or suggest, recommend things on that. But the rest, Chair, 3 years out of date, doesn't inform us much, really. It's got to be either within a year or two, otherwise it just isn't worth reporting, in my view. Sorry.
No, I think that's fair, and perhaps a principle that's within 12 months would be a cut-off. If not, we'd need to look for other data sources, would be or ideally sooner than that, but we've got to start somewhere. So thank you. John, I'll bring you in.
Yeah, well, I mean, these are all important comments. Intelligence is the basis of public health advice and action. And developing a good public health intelligence function within West Berkshire Council is a priority. Until now, there's been a shared function between Reading and previously Wokingham and West Berkshire. And in the future, there will be a focus of public health intelligence within West Berkshire Council. And some of the issues that have been just raised should be addressed by that and by better integration of the public health intelligence with the corporate intelligence of the council. It's also, worth just referring back to what happened in the pandemic, where local directors of public health were very critical of the way in which local data was captured and hoarded by London and not provided back to local directors of public health to focus the intervention and prevention work during the pandemic. And that really is a manifestation of something which has been a very long time trend. I mean, in the Victorian period, the Times used to publish weekly bills of mortality for the country. Local papers used to publish the death rates and so on, because the registrar's office was local, the data was captured locally, and it was readily available to be played back into the local community through the local press. I think as we develop the health system locally, you would hope that the intelligence that is developed in primary care settings and in the primary care networks will become a rich source of intelligence for this work. But at the moment, Guyan is an interim worker in intelligence. We have a couple of others who are shared with Reading and so on. And if people are as keen as it sounds on having good intelligence that's timely, then the council needs to invest more in intelligence capacity, because all of these things are needed and are important. So I just flagged that up, really, that if the new Director of Public Health comes looking for support for more investment in intelligence, then I hope that people will put the money where the mouth is on this one. Thank you.
Thank you, John. Are there any other comments? No. So I'd like to extend a big thank you to Guyan and the team who've done all the work on this. I think it's taken us a huge leap forward in the right direction, and the steer from this board today has been incredibly helpful. So we'll take that away and do some further work on this through the steering group, and then confirm at what point we start to kind of bring this here more regularly for assurance and helping to drive our work of this board. But thank you very much for all your really helpful comments. So I'll move on to item 13, which is the delivery plan progress report for priorities 4 and 5. And I believe we've got Dr. Heather Howells to present this item. Yep.
Yeah.
Hi, Heather.
Hi, by way of introduction, so my name is Heather Howells. I'm a local GP and one of the GP clinical leads for mental health for Bob ICB. I'm come to in place of Adrian Barker, who is the chair of the Mental Health Action Group, to present on priority 5. as he is away. Thank you for having me. So the report highlights, and I think by way of introduction, it's worth us just reminding ourselves the significant cost of mental ill health, both in terms of economic costs, human costs, and health and social care costs, as well as how common mental illness is, with 1 in 4 adults experiencing at least one diagnosis of mental illness a year. It goes on to set out the objectives against the strategy and the actions that have been taken on the delivery plan against that. I guess some key things to bring to that and achievements of the Mental Health Action Group. We had the talk on the cost of living crisis, and the Mental Health Action Group ran a really successful event looking at the financial problems and how these affect mental illness with a wide range of stakeholders. And it really highlighted the kind of social determinants of health, housing, employment, and environment, and how these have a significant effect on mental illness. The Mental Health Action Group has also been a key player in helping to guide and steer the development of the Mental Health Integrated Community Service. So this is a service that is part of the Local Mental Health Transformation Project, and is gone live in West Berkshire in January. And the Mental Health Action Group has had a key part to play in how that is rolling out in our area. The Mental Health Action Group also has secured a place on the newly reformed place-based mental health partnership. So again, we'll have a key focus on developing the mental health strategy for our area there. In terms of current priorities, the report highlights that their Mental Health Action Group has decided to focus on bereavement as part of the action against, to develop and promote a range of information and tools to support transition across the life course, and has agreed that a focus on bereavement at this stage will be helpful if you'd agree. We know that there are gaps in bereavement provision, particularly, for example, for people with a learning disability. And so there is some early work going on to look at that and map that across West Berkshire. And I guess one of the other key current priorities is the re-establishment of a mental health forum, so that we can really hear the voice of people with mental illness in our community. Health Watch can no longer provide the Thinking Together events, which were hugely successful. And so the hope is that the Mental Health Forum will in some way plug that gap to hear that voice. There was an initial group that was just had with which was well attended, and to really establish so that we can establish that in a co-produced way. Yeah, so open to any questions.
Thank you very much. Are there any initial questions or comments for Heather on the report? No, none on screen. April, was there anything that you wanted to add at all to Heather's summary? I know you've been involved in some of this work as well.
No, nothing else to add from me, Sarah, at the moment. Thank you.
Okay, thank you. So thank you. That I think is a really, really comprehensive update. In terms of the recommendations, I believe this is here on the agenda to note, but there are a number of recommendations that we are asked to consider. So first being to note the report and the progress made, and consider if the actions are still appropriate. I think if this is the recommendation of the subject matter expert group in this area, it feels reasonable for us to accept those unless there's any comments or questions on any of those. There's a particular recommendation that we agree any actions to be referred upwards to the place or system level. I'm not, from the paper, I wasn't completely clear what those, which actions they were. So maybe that's something we need to take away and discuss at the Berkshire West Mental Health Board, which helpfully Heather chairs, so we can agree which of those actions need to sort of that wider strategic view, and similarly then push some of those further up to a kind of a bob-wide level if we think it needs a greater scale of effort and input, unless there's any disagreeing views on that. No. And then finally, around committing our respective organisations to delivering the agreed actions, I think we're all committing our organisations' time and effort into this, and the working groups will work through whether the actions are deliverable or not within kind of current bounds, and do all we can to make sure we are delivering on this. So I don't think we're not taking a formal vote on this one, but that would be my chair's summary of the paper and the recommendations. Are there any other comments or any differing views? No? Excellent. Well, thank you very much for the presentation. Thank you for the paper as well. That's really helpful. So moving on, so we've got a number of items that are, well, were listed as not for discussion. I'll just run through these quickly. So item 14, the Better Care Fund monitoring report for 23-24. This had to be submitted to NHS England on the 9th of January this year with the necessary sign-off from the Health and Wellbeing Board chairman. So this is just here for noting today. Item 15. So this report is around changes to pharmaceutical services, and it provides details of recent and planned changes to pharmaceutical services in West Berkshire, and advises the board on the implications for the West Berkshire pharmaceutical needs assessment, of which we are the responsible committee for oversight and maintenance. We're asked to note the decision of the pharmaceutical needs assessment subcommittee that took place on the 17th of April, and note the recent changes to the opening hours of Halo Pharmacy in Thatcham. Having said this was for information only, that was the initial intention, but PCSE, and Gordon, remind me of the elaboration on that. Sorry, put you on the spot.
Primary Care Support England.
Thank you. Primary Care Support England since provided details of the comments made in response to the unforeseen benefits application in applications in Gaywood Drive, Newbury, and the Kingsland Centre in Thatcham. So we had a supplementary agenda pack to include the comments in relation to the Gaywood Drive application, and those were circulated on Monday. And the comments in relation to Kingsland Centre were only received yesterday, so they haven't been issued yet. So first of all, I want to ask, given the supplementary agenda item, are there any comments or representations that members want to make in relation to this item today based on the supplementary agenda? Yes, let's come in.
I just think we want to welcome these additional pharmacies that are proposed to be open. You know, the numbers may not stack up in official terms, but the need is definitely there. The anecdotal need from residents, definitely.
Mm-hmm. Thank you. Are there any other comments or questions on the screen? Oh, yeah, Councillor Paul.
Sorry, Sarah. Councillor McCraw had noted a comment to me as part of my handover that he'd like the board to review and respond to the proposed new pharmacy at Gaydon Drive. So if we can take that way as a review, I note that it was noted, and there are some comments within the pack. Mm-hmm. But I think it would be useful just to have that noted moving forward and have a response ready for when Alan's back.
Okay, yep, we can do that, yes. Excellent, thank you. Councillor Burke.
Thank you, Chairman. The previous pharmacies failed or were unsustainable. So these new pharmacies, I think, are going to have their work cut out to continue as going concerns. I wonder if there's a need for a kind of a longer term approach here. I have had experience 15 years ago of caring for a loved one in the 6 months prior to end of life, and I used to every week I used to do an inventory of how much, with the quantity of medicines that we had and varieties and so on and so forth, and the online services that people can enjoy now are so much better than polling up every week to a pharmacist. I think we need to kind of accept that that's the way we're going. Of course, that's not accessible to still a large number of percentage of the population, but I think a longer term approach is what we need here.
Thank you. We heard at the last Health and Wellbeing Board that there's a a paper presented by the Bob ICB colleagues who are responsible for pharmacy services, which gave a summary of the kind of current sustainability assessment and the longer term strategic intention in the primary care strategy, which covers pharmaceutical services as well. So that is something that is actively being considered and worked on through the ICB. And I might bring in April or John, because John's got his hand up, in terms of our reflections from a pharmaceutical needs assessment and public health view on that at the moment as well. But yes, you're right. The consideration of the longer term as opposed to individual pharmacies is very much something that's underway.
Thank you.
John?
Well, yes, just to support that intervention. I mean, the thing is, there are a lot of moving parts in this topic now, and as you've indicated, you know, we've got the online and digital and all of that. We've got the commercial dimension. I mean, where, you know, Boots and David Lloyd, not David Lloyd, you know, Lloyd's chemists, bought up loads of family pharmacies, and now they've been closing them down because they can't make it the model work. And at the same time, we've got in a parallel this new initiative on Pharmacy First, where the hope of government is that pharmacy can pick up a proportion of the work of general practice and of primary care at the same time as they are closing down. And I would add into that I think pharmacists have a bigger role than they've been following to date. I mean, it was Frank Dobson, when he was Secretary of State for Health, who said he discovered that pharmacists did 5 years of training and then they worked as shop assistants, and you know, not using the skill set that they've got to greatest effect, and using it in a public health context as well. I mean, I had experience in the 80s of pharmacists playing a very key role in harm reduction when we were faced with the HIV epidemic and an epidemic of heroin injection on Merseyside, and where the pharmacists played a very important role in that, in a real public health emergency. And we haven't really articulated what the public health role of pharmacists could be, given the political will. So, as I say, there are a lot of moving parts. What I've asked for, and this will obviously be carried out after I've finished here, is to stand back and take a look at this and to see what the future might look like. I mean, I haven't mentioned the rurality issue, which has been already raised today, but rural access to pharmacies, particularly for older people who are not digitally savvy and using online services yet, that obviously will all change over the next 20 years, I suppose. But so we have to have a multifaceted approach to making sure that we meet the needs of different areas, rural and urban, and different demographics, and people with and without transport. So I'm just really underlining what was previously said, and I think this is important that this board continues to keep an eye on this.
Thank you, John. I'll bring in Fiona.
Hello there. Hello. Yes, Healthwatch, we were asked by the Health and Wellbeing Board last year to have a look at wait times for pharmacies in West Berkshire. And I just wanted to update you to say that we will be producing a survey over the next month across Berkshire West, but we're going to be doing it in slightly different times. Because of the new Pharmacy First directive has come in now. So we will be looking at that over the coming months and how that's affecting residents and what's going on there. And that will be including wait times across the rurality of West Berkshire and obviously in the urban areas too. So I just wanted to let you know that we do have that survey coming out in the next month or so.
Excellent, that's good news. Thank you very much. So there's been a lot of helpful discussion here. I think a lot of it relates to the longer term strategy as opposed to these individual applications, but very helpful for us to take away and consider. Councillor Poole, could you just remind us of Alan's additional representation that he wanted you to raise, and then we can kind of agree the general thrust of a response, noting his additional representation.
So the additional representation was purely in relation to the gate and pharmacy. He wanted to review the transport, noting that there are other parking which is closer to the site, as well as just having a review of that site in general.
Thank you. So I think what we need to do then is probably delegate the wording of the response to the Director of Public Health in consultation with the Health and Wellbeing Board Chairman, which hopefully is Alan, who made the representations as well. So on the assumption that that doesn't make a material change to the view proposed in the paper, I think that we as a board will delegate that to the chairman and the Director of Public Health to agree the final wording of the response.
That's good.
So I'll propose that as our action. Can I get a second? Someone to second that? Thank you very much. And then a vote. So if we're for taking that course of action, please raise your hand. Anybody against? Anybody abstaining? Okay, thank you. So we'll take that as an action. Excellent. So I'll move on to agenda item 7, which is members' question. And thank you to Councillor Burke, who's asked both of the member questions, and you're here with us in person today. So I could ask you to take a lead on reading your questions, which are going to be answered. That question A by Councillor Codling. Okay, straight over to you, Councillor Codling.
Yes.
Sorry, your microphone's still not on.
Oh.
There we go.
Apologies. The school continues to face significant challenges providing learning for children in the temporary classrooms. This has been an ongoing issue for quite a number of years now. The school is working with determination to overcome the lack of proper heating, poor ventilation, and limited space to teach any one-to-one provision and regulate those children that need it. The property team are working closely with the school and are very aware of the issues and are supporting the school with addressing them. The school remains a high priority within the capital programme for 24-25. Do you have a supplementary question?
I did have a supplementary question, Councillor, but you haven't answered my primary question. What has been the effect on the health and well-being of children being taught in that environment?
I don't have any data as such, and it's just a general answer that I can give you.
Your answer was about progress, which is valuable, and I thank you for that. But what about the children?
We've recognised that there are challenges there. I don't have any specific data about their health.
Okay, thank you. So I'll move on to our second question, which I think we've got Sophie Widdiston joining us online, who's the Quality Improvement Lead for Children and Adolescent Mental Health Services for Berkshire Healthcare Foundation Trust. So Sophie, could I hand over to you to provide an answer to this question?
Yes, thank you. We've sent over a written response, but I'll talk you through it. So we've provided a table of data which shows the mean and median wait for first appointment across all of CAMS teams, our common point of entry team, which is the front door to CAMS, and then the specific teams under CAMS that have a direct access route. So majority of referrals go through common point of entry, but some teams do have a direct access route. So waiting times for first appointment does vary across teams. And the waiting times have been calculated over the last 6 months from October 2023 to March 2024. Looking at the mean wait for all CAMS teams, it's 5.6 weeks for West Berkshire patients currently. There's quite a discrepancy between mean and median. So the median wait is 1.5 weeks across all CAMS teams. For common point of entry, the mean wait is 8.7 weeks. And then there's the varying different waiting times for first appointment across the other teams. I don't know if you want me to read all of those out. But we recognise that there is need for further improvement in our waiting times, and we are committed to it. It remains our highest priority, sort of service improvement priority, really. Some of our CAMS teams have national waiting times from NHS England. So our crisis service, our early intervention in psychosis service, and our eating disorders service all have sort of nationally mandated targets. And in Berkshire Healthcare, we're meeting all of those standards, which is great. But we have a vision for all children and young people that come into contact with CAMS to have their first appointment within 4 weeks. And we're working towards that. And I appreciate this data is the mean, so it's a summary it's an average over a period of time. But our monthly data shows a downwards trend, which we're really pleased with, but we recognise that there is still work to be done. And we're using a quality improvement approach, which is based on lean methodology to do that work. And that's very much part of my role as the quality improvement lead for the service.
Thank you very much, Sophie. Is there a supplemental question?
Yes, I'm pleased to hear that the wait times are not as high as I anticipated, because like many other elected members, West Berkshire, I have had I have casework brought to me where families are waiting years rather than weeks for their first CAMS appointment, and I know that the office of our MP, Laura Farris, regularly receives escalations from families who have extended wait periods. So I guess my question is there a cohort of significant outliers in that data, which is seriously troubling families?
I think sometimes the discrepancy is what is a first appointment for people. So for families and for young people and children, they may see their first appointment, their first meaningful appointment, as receiving therapy or receiving a specific intervention. But the question that came to us was, when is the first appointment with CAMS, not the first treatment appointment? And the NHS England definition of waiting is first appointment where support and advice is offered at the first appointment. So families don't always see that that's their first appointment, but it is their first appointment. But we appreciate that it's not the most meaningful appointment to them. It's not the appointment that they want that is going to give their child the support and intervention that they need. So I think it's the definition of first appointment that's the variation, I guess, because there are some cases within the service that I guess we sort of call our teams that have the longest waiting times for treatment, and there are some much longer than what we would like waits in some of those teams, and they're the key teams that have focused work happening to reduce those waits for those families.
Thank you. I'll allow a further supplementary question, and then we'll.
Thank you, Chairman. So I guess I asked the wrong question. So I wonder, not for now, but could you come back and let the board know what the real question is? When do our young people who need that level of support start to receive their treatment?
Yeah, there's a few different ways in which we can define it, but yes, we can provide further information on when does intervention commence, if that's what you want to do for.
I recommend we have this perhaps as a substantive agenda item at a future board to go into the level of detail. I think that would give a level of assurance. That's fine. Thank you. Thank you very much for joining us, Sophie.
It's okay. Are there any other questions?
No, that's everything. Thank you.
I've got one, if I may. Hello?
Sorry, John. Technically, supplemental questions only come from the person raising the original question. So should we take that one and make sure that any questions you've got inform the substantive agenda item that we'll bring to a future Health and Wellbeing Board?
Yeah, but, well, I don't know. The moment will have passed, won't it? I just wanted really to say something following up from what that conversation was about, because
You can make
I
a
think
statement, yes.
I think this is a national issue, the way in which the data is being used. I mean, I'm familiar with it in South Lakes, where people will get referred, and then, you know, they're counted as having been in treatment when they're not in treatment. They've just been seen, and then they go on a waiting list for 2 or 3 years. And so it's not meaningful in any meaningful sense. So we do need the proper meaningful data. And the other consequence of that is that because people realise that the services, and this is not a criticism of the services in Berkshire, it's a national problem, because people realise the services are failing, that there may well be suppressed demand, that people don't bother getting referred in the first place. So we really need to have surveys of family doctors and others to try and ascertain how many youngsters would be referred if we had a responsive, timely service.
Thank you, John. Comments noted, and we'll consider that for the future agenda item. Thank you. Thank you again, Sophie, for joining us.
Thanks.
So that segues quite nicely onto the forward plan for the Health and Wellbeing Board, which is included in the papers. Just in addition to what's shown in the forward plan, it's subsequently been suggested that the following items should also come to the next meeting. So that will include an update on the Hampshire Together project, following their recent public consultation exercise. That's the consultation on the future configuration of Hampshire hospitals. And the second item on the results of the recent CQC review of the Council's adult social care services. So they're proposed to come to the next meeting. We've had a couple of notes throughout this meeting around things that are going to be added to the forward plan, which Gordon is making notes on and will include in the next iteration of the forward plan. But can I invite any other comments or suggestions on the forward plan? Fiona?
Thank you, Chair. I would like to raise something with the board. Can you hear me okay?
Yes.
Good. The Women's Hub project was raised by the NHS last year, and it should have been running for about 12 months by now. But there's been no movement in Berkshire West. So Healthwatch has kind of followed that up with Oxford and Bucks there, Bob. And Berkshire West, we haven't had anything as yet at all. And unfortunately, we've found that the funding for the first year of the project has apparently been absorbed into the Bob deficit. So we are writing a letter to ask what's happening with it. NHS England have recently sent out a letter to say that to all of the ICBs across the country for this particular project, to say that to ask them basically what's going on and how have they spent the money so far, and if it hasn't been spent, then they will be clawing it back. So we have asked them for clarity on what's happening with the project and what's happened to the first year funding, and the second tranche has come through now, but we're asking what's going to be happening with the second year funding. And I just wanted you to know that was the issue at the moment.
Thank you. It's not my portfolio area, but I can take that away as a question to raise, and we can consider where an update on that might work into the forward plan. Noting at the next meeting, I'll be presenting the ICB's draft annual report for 23-24, so that might sit neatly with that item as well as a particular area of interest of this board.
Okay, thank you.
Fiona. John? Oh, you're on mute still.
Sorry, okay. The public health annual report will need to come at some point. I don't know whether Gordon knows the timing of that. I mean, it's in draft form at the moment, and it will be ready by June.
So that's on the forward plan for our meeting in July?
Okay. What's the date of the meeting in July?
The 11th of July.
Oh, well, that'd be my penultimate day. So it would be nice to be able to speak to it before I finish. Okay, that's good. Thanks.
Thank you. Any other suggestions? Yep.
Yeah, I was just going to suggest that it may be on the back of the discussion that was at the last meeting around vaping. Obviously, we've got the new tobacco control and vaping legislation coming in. And it may be helpful later in the year to look at the kind of holistic approach to implementation at local level, because it's not obviously not just about enforcement, it's about awareness and education and everything else, and how that fits in with those strategies.
Okay, thank you. No, we'll take that away to consider. Any other suggestions? No? Excellent, thank you. That's all helpful steer. And so the final item is item 19, future meeting dates. So these are planned in for the 11th of July, 12th of September, 5th of December, 6th of March, and the 8th of May. And I'm sure you've all got diary holds in for those. So there's no other business. So I'd just like to say thank you very much to everybody for the meeting. Apologies, it's been a little bit cold in here. They're keeping us on our toes, and looking forward to seeing you at the next meeting. Thank you.
Thank you, Chair. Bye.